you. So, good morning, everybody. Thank you for joining us on our weekly CAT conference. This week we have a good friend, Raul Moreno, from Madrid, Spain. I know Raul for a long time and is someone I respect a lot in the field of interventional cardiology. And we talk about a very topical area right now, which is antithrombotic therapy after TAVI, or TAVR as we call it in the United States. Raul, when I came to New York, I was surprised how much confusion there was about antithrombotic therapy after TAVR. There are lots of misconceptions. People think of this as a drug-eluting stent or as a coronary stent. And even when I first came here, I saw patients who were, physicians were concerned sending patients with TAVR because they thought they couldn't take antithrombotic therapy afterwards. So it'd be nice to hear, your views on what we should be doing and what the data says. Thanks, Raul.
Okay, thank you. Good morning, everyone. It's a pleasure for me to share the beginning of the morning with you. So my good friend, Asil Latif, thank you very much for giving me this opportunity. It's a honor for me to share with you these minutes. We're going to speak about the state of the art today of antithrombotic therapy after TAVI. And when we speak about antithrombotic therapy after TAVI, we have to consider three main clinical endpoints. One of them is the stroke, second, the valve thrombosis, and third, the bleeding complications. Regarding the stroke, a stroke occurs in about 3-4% of patients after TAVI. This is similar to what occurs after surgical aortic valve replacement. Of course, if we perform an MRI to patients, there are going to be many patients with silent cerebral lesions. And the stroke increases mortality in 4 times. This is so a very important clinical endpoint. The problem we have is that there are no clear clinical predictors of stroke after TAVI, so we don't know what patients are at high risk of suffering a stroke before doing the procedure. What we know is the timing of stroke. We know that most of the strokes occur during the procedure or during the first 24 hours after the procedure. But beyond the first 3-4 days, the risk of stroke is much lower. And this is important to be considered when speaking about the antithrombotic therapy after TAVI. The second problem is the valve thrombosis. The valve thrombosis is not very frequent. The frequency could be about 1.6%. Typically occurs in about 6 months after the procedure, but it may occur several weeks or even years after the procedure. The typical clinical presentation is heart failure with dyspnea. The typical echo finding is an increased mean gradient. And what it is very important to know is that most of the patients with valve thrombosis have a solution of the problem with appropriate anticoagulation. But we could be underestimating the problem, speaking about valve thrombosis, because one thing is valve thrombosis, but other thing is the hemodynamic valve deterioration after TAVI. The hemodynamic valve deterioration is usually defined as an increase in more than 10 millimeters of mercury in mean gradient. It may occur, according to this study, for example, in more than 4% of the patients. And what is very important to be considered is that, for example, in this study, patients that receive anticoagulation after TAVI had a significantly lower risk of hemodynamic valve deterioration after TAVI. And what this suggests is that many patients with valve deterioration after TAVI could have thrombotic complications as the cause, as the reason of the problem. And the third problem is bleeding. Bleeding complications, of course, are one of the main clinical endpoints, but I'm not here speaking about the periprocedural bleeding, but the bleedings that may occur during follow-up after the TAVI. In this study, for example, late major bleedings, so bleedings that occurred after the first month after TAVI, were evaluated. And what you can see here is that patients that suffered any major bleeding more than 1 month after the procedure had more than 2-fold mortality in comparison with patients that did not suffer any bleeding complication. And this is even more important, I think, had a significantly increase of cardiac death in comparison with patients that did not suffer any major bleeding, 13% mortality versus 5% in patients without bleeding. What happens with patients with that we are going to treat with TAVI? The problem is that TAVI patients are typically a population that has an increased risk of thrombotic complications, but also an increased risk of bleeding complications. And this makes very frequently difficult to choose the appropriate antithrombotic therapy after the procedure. These patients have frequently a coronary stent, have frequently atrial fibrillation, have a mean age of about 80 years old. These patients have frequently anemia, heart failure, renal failure, etc. What are the current recommendations still in the guidelines? The recommendations we have, we could speak separately about the patients that have sinus rhythm. This accounts about 2/3 of patients, and patients that have atrial fibrillation, and this may have about 1/3 of patients. In patients that have a sinus rhythm, still many guidelines recommend aspirin and clopidogrel for several months. And this is mainly based on the history of coronary stents, although patients at high risk of bleeding could be treated only with one antiplatelet drug. And in patients with atrial fibrillation, of course, oral anticoagulation is indicated. Usually, it is recommended in the guidelines to associate low-dose aspirin, but no other antiplatelet therapy, so triple therapy is discouraged. And regarding the new anticoagulation, the new anticoagulant therapy, these drugs have not evidence during the first 3 months after the procedure. So during the first 3 months after the procedure, what we should give is vitamin K antagonist. And beyond the first 3 months, we could give new or anticoagulation. So we are going to speak separately about patients with sinus rhythm and patients with atrial fibrillation. And in patients with sinus rhythm, we have to speak now about the question of if it is needed to add clopidogrel to aspirin or not. So what is the rationale for giving aspirin and clopidogrel after TAVI? There are many reasons to give clopidogrel and also many reasons not to give clopidogrel. To give clopidogrel in association with aspirin, the main reason, there are several reasons, but the main one is that we have been thinking during many years that this is similar to a coronary stent, and coronary stent patients receive double antiplatelet therapy. But we have to consider that TAVI is not a coronary stent. Bleedings are more frequent than thromboembolic events after TAVI. Clopidogrel increases major bleedings, especially in this type of patients, elderly patients. And what is very important also to note is that double antiplatelet therapy does not prevent subclinical valve thrombosis. And this is one of the problems we are thinking about when we speak about antithrombotic therapy. Before this year, so before 2020, we had 3 randomized trials, 3 small randomized trials that compared aspirin alone and aspirin plus clopidogrel after TAVI. There are 3 small trials, one with 80 patients, one with 120 patients, and the other trial with more than 200 patients. These trials, the 3 small trials, showed that adding clopidogrel to aspirin did not prevent stroke, myocardial infarction, etc., but conversely increased risk of bleeding, although sometimes the differences were not significantly different because these are more small trials. When we go to the Anti-trial, the Anti-trial included more than 200 patients, and in this trial, the risk of bleeding complications reached statistical significance, about 3 times higher of bleeding complications in patients treated with aspirin and clopidogrel, and the associating aspirin to clopidogrel did not prevent ischemic events, and even numerically, the risk of stroke, for example, or myocardial infarction was numerically higher in patients with double antiplatelet therapy in comparison with patients with aspirin alone. This year, and this is one of the reasons for choosing antithrombotic therapy for speaking today with you, this year has been published the POPULAR-TAVI trial in both cohorts. And the POPULAR-TAVI trial has included two different cohorts of patients. One of them, patients with indication of oral anticoagulation, cohort B, and patients without indication of oral anticoagulation, cohort A. In the cohort A patients, there were about 700 patients that were randomized to aspirin alone or aspirin and clopidogrel, and in the cohort B patients were randomized to oral anticoagulation alone or to oral anticoagulation in association with clopidogrel. The cohort A patients were patients without indication of oral anticoagulation. These patients were randomized to aspirin or to aspirin and clopidogrel. These patients were followed up for 1 year. And what we can see in this slide is that we could expect, of course, that patients receiving aspirin and clopidogrel had an increased risk of bleedings and an increased risk of non-procedural bleedings with a clear statistical significance. This was, of course, obvious for us, and this was expected for all of us. What is important is that the risk of ischemic events, including cardiovascular mortality, ischemic stroke, or myocardial infarction, did not have any reduction adding clopidogrel to aspirin. Even during the first months, there was a higher risk in the arm with aspirin and clopidogrel. And if we consider all the events, so ischemic events and bleeding complications, that is what we have here, there was a significant increase of overall events in patients receiving aspirin and clopidogrel. In this table, we have separately all the events, and in red we have the ischemic events. We can see how the risk of a stroke or myocardial infarction was even numerically slightly higher in patients receiving both drugs. So we don't have any reason today in patients that have been treated with the TAVI and have sinus rhythm to give clopidogrel in association with aspirin if we don't have any other indication, as for example, if the patient has been treated recently with a coronary stent. And we are going to have now the group of patients with atrial fibrillation. These patients are very frequent. If we have about 12 patients after TAVI, about 4 of them have a prior atrial fibrillation, and about 1 patient out of 12 have a new onset atrial fibrillation. So this is a very, very frequent population. These patients, of course, have an indication of oral anticoagulation. These patients have a worse clinical profile, patients with atrial fibrillation have more comorbidities, have a more advanced age, and these patients have also a worse hemodynamic profile with a lower left ventricular ejection fraction, a higher pulmonary artery pressure, and a lower stroke volume. And because of all reasons, patients undergoing TAVI that also have atrial fibrillation have an increased risk of death, stroke, bleedings, heart failure, hospitalization, and also an increased risk of frequency of futility as an indication of the TAVI. Of course, patients with atrial fibrillation that are treated with TAVI have a clear indication of anticoagulation. And the question is that if we can give NOACs instead of vitamin K antagonists in patients that have undergone TAVI. And we have 3 randomized trials that have evaluated or are evaluating NOACs in patients after TAVI. One is the Galileo trial with rivaroxaban, one is the Atlantis trial with apixaban, and the last one is Envisage AF trial with edoxaban. Rivaroxaban is a very peculiar study, included only patients without indication of oral anticoagulation, so patients in sinus rhythm. And apixaban is being evaluated in the Atlantis trial. The Atlantis trial is including patients both with sinus rhythm and atrial fibrillation. And the Envisage trial is including only patients with atrial fibrillation. So atrial fibrillation, so Envisage trial is the most important trial focused on atrial fibrillation patients that are undergoing TAVI. We now have the results published of the Galileo trial. The Galileo trial was planned to include 1,500 patients and to follow up these patients for more than 2 years, or about 2 years, but this study was stopped prematurely because it was seen that the rivaroxaban was harmful in patients undergoing TAVI without an indication of oral anticoagulation. These patients were randomized to rivaroxaban 10 milligrams daily in association with aspirin for the first 3 months, or to double antiplatelet therapy with aspirin and clopidogrel for the first 3 months. And what we know of this trial is that this trial had a significant increase of the clinical primary endpoint with the rivaroxaban in comparison with double antiplatelet therapy. And in this study also there was an increased risk of mortality. So it is clear that there are no indications to give oral anticoagulation in patients undergoing TAVI if these patients don't have any other clinical situation. The Atlantis trial is comparing, including patients with indication of oral anticoagulation or without indication. Patients with indication of oral anticoagulation are being randomized to vitamin K antagonist or apixaban, and patients without indication of oral anticoagulation are being randomized to apixaban or double antiplatelet therapy or single antiplatelet therapy. So we could say that the Stratum 2 is similar to the Galileo trial, but with apixaban instead of rivaroxaban. And this is the Envisage AF trial that is now finalizing the clinical follow-up. This study is evaluating the edoxaban in comparison with vitamin K antagonist in patients with atrial fibrillation and undergoing TAVI. And the final question could be, if we have a patient undergoing TAVI and this patient has atrial fibrillation, of course, oral anticoagulation is indicated. And the question is, do we need antiplatelet therapy in association with oral anticoagulation in these patients? Now we have, as I told you before, the cohort B of the POPULAR-TAVI trial, but before we had non-randomized data, for example, in this study with more than 600 patients with double antiplatelet therapy or with single antiplatelet therapy in comparison with those receiving vitamin K antagonist alone, did not have any reduction in terms of ischemic events such as myocardial infarction or a stroke, and did not have any clinical advantage. But we have now the randomized trial, the cohort B trial, and the cohort B trial of the POPULAR-TAVI is comparing oral anticoagulation alone versus oral anticoagulation plus clopidogrel for the first 3 months. What we know in this study that has been already published is that this is obvious, what we have in this slide. It is obvious or expected that patients receiving clopidogrel in association with oral anticoagulation alone have a significant higher risk of bleeding complications, not only all bleedings, but also non-periprocedural bleedings. But what it was not expected was that patients receiving oral anticoagulation and also clopidogrel did not have any significant difference in relation with ischemic events, but numerically you can see how patients receiving both drugs have had an increased risk of bleeding of ischemic events, 17% versus 13%. And if we consider how what happens with the overall events, it is an increased risk of overall events with both drugs, 45% in comparison with oral anticoagulation alone. So we have here separately the ischemic events. In patients receiving clopidogrel, there was a non-significant but numerically higher risk of ischemic stroke and a similar risk of myocardial infarction, and a non-significant but numerically higher risk of cardiovascular death in patients receiving both drugs. So this is the last slide. I think that the most important complication is that most patients undergoing TAVI only need one drug. When speaking about antithrombotic therapy. If the patient has not any indication of oral anticoagulation, the patient has to receive aspirin alone. There are no reasons to associate clopidogrel or any other drug if the patient, for example, does not have a recently implanted stent, for example. And if the patient has an indication of oral anticoagulation, the patient has to receive or anticoagulation alone. We have to wait until the results of the Atlantis trial and the Initiates trial to prescribe NOAC after the first 3 months. So according to these studies, what we should give is a vitamin K antagonist for the first 3 months and our anticoagulation alone after the first 3 months. This is the theory. In the practice, at least for me, it is difficult in patients that are receiving already new anticoagulants, direct anticoagulants, and undergo TAVI. For me, in the practice, it's difficult to convince them to go back to vitamin K antagonist. So I think most of us are maintaining the DOACs in patients with atrial fibrillation undergoing TAVI, but what we have to know is that there is no evidence for giving these drugs. Of course, we may have some pending questions. For example, do we have to give a loading dose of aspirin before TAVI or not? And for example, other question could be if the type of device, for example, supraannular, intraannular, self-expandable valve, balloon expandable valve, if these type of questions, or if the different device could mean any difference in the antithrombotic therapy. So thank you very much again, Asim, for giving me this opportunity, and we are open to the questions we may have.
Raul, thank you so much. That was great. I'm going to let Shun come on for the questions, but maybe Juan, you had a couple of comments you had during the talk.
Yeah, no, we're talking, Raul, about the reasons why behind actually why we think anticoagulation could be useful. And I think that we're talking about the short-term versus the long-term effect. And one of the big things that people are concerned about is durability of the leaflets. Exactly at the introduction, for example, in your slide, you put that allowing the leaflets to get covered with proteins and get actually thickened is actually one of the most important mechanisms of leaflet deterioration. And it makes a lot of biological sense, but as actually you've shown, it brings an inherent risk. So, I mean, it's difficult to really balance without data the need of improving leaflet durability over time and reconciling the high mortality rate associated in the short term with the use of NOAC. So it's a complex problem, but I agree that there is something there to think about also when it comes down to durability, especially in a younger population.
Yeah, I fully agree with you. We participated in the Galileo trial, and I thought the Galileo trial was going to give us positive results. Mainly because sometimes biological valves that are implanted surgically receive anticoagulation for the first several months, and also because we have the problem of valve thrombosis and the hemodynamic valve deterioration, so it makes sense. And also, other reason is that there are some patients that we think that these patients don't have any atrial fibrillation, but if these patients have continuous monitoring during the following month, for example, some of these patients have an atrial fibrillation. So it makes sense. And to be sincere, I thought the low dose of rivaroxaban was going to be good. But here in the slide of the Galileo, even during the first 3 months, there is also separation of the curves. So there is no things. And also we have to consider that the blue curve is double antiplatelet therapy. What we are saying now is that these patients should go to single antiplatelet therapy. So if the control arm was the single antiplatelet therapy, that I'm sure that the guidelines are going to change, this difference could be more important even. So I agree with you. I think that it makes sense, but we have to wait the results of the trials. We have to wait also this. I have here the Atlantis trial. It could be that the Atlantis trial was positive with the apixaban, but I think that the apixaban is going to increase the risk of bleeding complications, and we have seen in other trials, because the risk of myocardial infarction in patients with undergoing TAVI is very low. This is very different in comparison with patients undergoing TAVI, and the risk of stroke after the first hours is actually also very low if the patients don't have any indication of anticoagulation.
Right. You know, the other thing also, it's going to be very difficult. You know, I agree with both of you. I think it's fascinating giving DOAC or anticoagulation for the first 3 months and what impact that's going to have on valve deterioration, valve durability. But just doing that study is going to be very difficult,
Very
right?
difficult.
Because you're going to have to follow up patients for 8 to 10 years.
For a long time.
You know, before you actually see any real difference. So, you know, to get to your primary endpoint is going to take a long time, and it's going to be a challenging study to do.
What I think is very important is, so we have the problem of hemodynamic valve deterioration. We have the theory, and probably thrombosis of the leaflets play an important role here. What I think is very important is to follow the patients as usually with an echo every year. This seems obvious, but at least I don't know what happens you are in the US or in New York, etc. But here there are many patients in which during plan the TAVI, and the cardiologist forget about the patient, and you see the patient 3 or 4 years later. These patients may have an increased gradient, and this is the first echo the patient undergoes after discharge. So what may be important is to early detect patients with valve deterioration and with valve thrombosis, because theoretically, if we detect an increased risk of gradients and we prescribe anticoagulation for several months, it could be easier to solve the problem.
Yeah. You know, in the US, because of the TVT registry that we all participate in, we have to give data annually. So we bring our patients back annually for an echo and a visit. And that will help build up, I think, a lot of data here in the United States. Maybe just one comment about Galileo or question. I mean, they did do a sub-study looking at 4D CT and leaflet thickening, right? So there is some benefit in that study, if I'm not mistaken, from giving rivaroxaban. I mean, do you think there is, Raul, a sweet spot where, you know, we can use these drugs to prevent thickening without increasing bleeding?
Yeah, this is the problem when we consider separately an image of the patient or a number of the patient. Of course, it makes sense, and I'm sure anticoagulation with rivaroxaban or with any other anticoagulation prevents valve thickening, etc. But the problem is the cost of this prevention, and the cost is clinical events. So it is as in the acute coronary syndrome, we have if we use 2B3 inhibitors for all the patients with an acute coronary syndrome undergoing PCI, we are going to reduce thrombosis, of course, but we increase the risk of bleeding complications. So I think it is consistent, the reduction of thickening of the valves, but the problem is the cost of the clinical events.
Okay. Shun, so I'll leave it to you now. Sorry, we took up a little bit of your question time, Shun. Go ahead.
Thank you for a great lecture, Dr. Moreno.
So,
I think it was obviously a great review of how less is more. And we've seen from the stent studies how less medication, less bleeding, the better outcome for the patients. And the more we take away, sometimes it's more for the patient. And if we follow the same thing from the stent studies, I think bleeding risk, assessing of the bleeding risk is the key, it seems like. And if the bleeding risk is high, then obviously take away. If it's low, then you know, there's no benefit in adding more and more medication. Just a kind of challenging case maybe, if the patient had an AFib and a recent stent, what therapy would you offer that patient?
I think these patients should undergo the regimen that has been shown in the current symptoms. Or in that after current stenting, probably I could prescribe anticoagulation and during some months clopidogrel. Clopidogrel could be 1 year, 3 months, depending on the clinical situation. But I think that here the results of the trials that have evaluated NOACs in comparison with 2 or 1 antiplatelet drugs, I think anticoagulating the patient and one anticoagulant and one antiplatelet drug, I think this makes sense. So, for example, anticoagulation plus clopidogrel.
So no duration of triple therapy.
The problem is that in the trials, the Pioneer AF, all the Entrust trials, these trials compare. This is a limitation of these trials, not compare oral anticoagulation with a NOAC or with a DOAC plus clopidogrel versus triple antiplatelet therapy. And in these trials, giving double antiplatelet therapy was better than giving triple antiplatelet therapy. I think we have, of course, we have the limitation of these studies that we don't know what happens during the first days, because, for example, in one of these trials, the randomization was done in about 7 days, and probably patients during the first 7 days received triple antiplatelet therapy. So I think oral anticoagulation, clopidogrel 1 year, and could be during the first days triple antiplatelet therapy, but I think for the most 1 week, giving the opportunity of this 1 week of the window that these studies gave to the randomization. For example, in the Entrust AF trial, one of the reasons or one of the explanations we can have in comparison with other trials is that the randomization was done hours after the PCI. So patients received double 2 drugs instead of 3 drugs since the first day, in comparison with the APIC-7 trial that maintained the patients during the first week. So the first week, I think it is reasonable to maintain the first week with the 3 drugs. Of course, all the patients are different. It is not the same a patient with a mid-right coronary artery or with 2 stents bifurcation. Of course, I think it could be different, but I think this could be the answer.
Thank you. I think another challenging group of cases are valve-in-valve cases. We actually did a case a few weeks ago, valve-in-valve, and Dr. Ortiz recommended for NOAC monotherapy. And any comment on the role of anticoagulation in valve-in-valve cases to decrease incidence of early valve degeneration?
Yeah, valve-in-valve procedures have a higher risk of many complications. One of them is the deterioration. The deterioration could be partially related with the higher gradients we have immediately after the procedure. So it's a false deterioration. And it makes sense that the use of anticoagulation here could be different, but we don't have proof. So I think we don't have any reasons now. If a patient is undergoing a valve-in-valve procedure and has a sinus rhythm, this patient, we don't have reasons today to prescribe anticoagulation. We don't know in the future, but of course the trials that have evaluated this problem, the Galileo and the Atlantis trial, don't have patients to conclude this to make this conclusion.
Yeah, I agree, Raul. There's no randomized data. We've a little bit been basing it off registry data. So, there are 2 manuscripts, one from Muhammad Abdel Wahab that we published in Circ Intervention, where the risk of clinical valve thrombosis, so not even subclinical, but with gradients with symptoms, was in the range of 6%, 6.7%, so pretty high. And then the other area we worry about even more than aortic valve-in-valve is mitral valve-in-valve. because of the flow state and so on. So we've also there been giving, in discussion with our surgical colleagues, been giving 3 months of anticoagulation because of our concerns of valve thrombosis. And also, there's a paper by Yoon in the European Heart Journal also showing again, 6 to 8% risk of valve thrombosis. But I agree with you. We don't have any randomized data, but the mitral one really makes a lot of sense. I think particularly what we've seen with, all these big mitral prostheses, the way the flow changes, the dead space is created, but we need more data. So I don't think there's a guideline indication. People are doing it very much based on their own clinical practice.
Yeah, I agree with you. Yeah.
So another question from the chat. There's a question whether administration of protamine at the end of the procedure, do you always administer it?
Good question. So protamine immediately, yeah. For example, in my center, we prescribe protamine. We prescribe protamine, and we don't prescribe a loading dose of aspirin before the procedure. And we do it routinely because we are thinking only about the bleeding complication. But I'm not sure if we are if this is the correct indication of or not. 2 weeks ago, we had a patient that with sinus rhythm, so no atrial fibrillation prior the procedure or during the procedure. The patient had an inferior myocardial infarction. After 2 hours after the procedure, we performed an emergent coronary angiography, and the problem was not a compromise of the ostium of the right coronary artery, but an embolization of the distal right coronary artery. So these type of cases make you think about if you are doing the right things. So see if we should give protamine or not, and if we should give a loading dose of aspirin before the procedure or not. Of course, this is the beauty of this topic of antithrombotic therapy after TAVI, that everything is to be demonstrated, and we are at the beginning because we think that there are many studies now, but if we speak only 10-15 minutes, every one of us have a particular cases that need further evidence. So these type of things are open to future research, and I think during the following years we will have many interesting studies.
Yeah, I mean, we do something similar here in New York and Monty. We don't give loading doses of antiplatelets. We actually start the antiplatelets after the procedure. And we give routine protamine in TAVI. We used to also give routine protamine in mitral clip, but we've stopped. Okay, because we've had now one, and you always changed by your anecdotal experience of the one bad case. But we recently had a patient, who had a massive stroke after a mitral clip, where we had a very good result with the mitral clip, and he had a massive stroke and actually died because of the stroke. Did the protamine contribute? I don't know, but those of us who've done mitral clip all see those cases where you get a good result, you start seeing a bit of smoke in the left atrium or a bit of sludge in the appendage, that you decrease the washout of the left atrium. And so I've become very concerned that maybe the mitral patients are higher at risk for these kind of complications from protamine.
Yeah, theoretically the solution could have been by valurudin, because we are treating all patients, but we have the Bravo C trial in which heparin was compared with valurudin, and valurudin did not give any clinical advantage. So we don't know. Probably I think we have to be using unfractionated heparin for many years still during these high risk procedures for bleeding and for thrombotic events, and the use of protamine will be still controversial. But the problem is that what is more frequent, if bleeding complications or vascular complications, probably the individualization, treating every patient as a different patient could be the solution. So maybe we could separate patients that need protamine and patients that don't need protamine. And probably it depends on the vascular access, the type of device you are using, how the feeling you have when entering the sheath to implant the valve, etc. No?
Yeah, good point.
There's a question from Dr. Menegas. Do we think that the valve deterioration in TAVI is different from surgical AVR, such as rate of deterioration or mechanism?
Yeah, the problem we have to compare results with surgical replacement is that the criteria for valve deterioration have been didn't exist even with the surgery, because the criteria was death or need for new surgery. So we didn't have until before the era of the TAVI, we didn't have echo follow-up echo studies for long term after surgery. So we have to construct now the evidence, and the evidence we have now is that the duration, the durability of the biological valves implanted by transfemoral approach is at least as good as valves that are implanted surgically. Even we have now the results of the long-term results of the NOTION trial with even better results. We have to consider that the results, the immediate hemodynamic results are even better with a lot of devices with TAVI than with surgery. And after the procedure have a higher gradients with surgery, it is easier to have bad hemodynamic profile of the valve. And of course, there are more patients with mismatch of the valve after surgery, etc. No, so I think, of course, we have to wait. But the valve durability is not a reason to send a patient for surgery instead of TAVI.
That's good.
I don't know if I've seen disagree with me, but I think the data, and I think the results, the good results of the TAVI at the long term will be demonstrated in the following years.
I completely agree, and the one thing is when we do demonstrate it, the durability, we'll be able to do it with better data than our surgical colleagues have collected, unfortunately, because we really now are collecting very good data on the long-term durability of these valves, echoes annually. In some of these studies, they will even go to the patient's house and do the echo, so you can get the echo at 8, 9, or 10 years. Okay. That's never been done in the surgical literature. And when you look at the surgical literature and you look at the actual numbers, at risk, when you get to 10 years, 11 years, 12 years, it's like small numbers. They start out with a large number and then it's tiny numbers, So I'm always love when I hear the discussion, and I hear a surgeon explaining to the patient how the valve is going to last 12 to 15 years, a biological valve. And then they're going to put in the Inspiris valve, which is the latest valve from Edwards that has no durability data whatsoever, but they're convinced it's going to be last 10, 12 to 15 years. So I think, we all need to be using the same definitions, but I think we really will have great data in a few years and well-collected data to be able to answer the question. I don't know, what do you think, Juan?
No, I agree. All the durability data is based on in vitro data. And that's why they talk about leaflet durability at 10 years, but not really properly collected, prospectively collected human data with imaging follow-up.
Yeah, well, I mean, it's interesting when you look at the Vivid database, so the valve-in-valve database that's got now a few thousand TAVIs in it, or valve-in-valves, the age of those prostheses is about 8 years, okay, of those surgical prostheses that we're doing valve-in-valve. The mean age is about 8 years. So this whole thing about 10 to 15 years, I'm not sure we have the data, even for surgical valves, to say they last 12 to 15 years. I mean, I honestly do what you just said, Raul. I tell my patients, that the TAVI valve and the surgical valve probably going to last about the same time. And right now we have pretty good data up to about probably 10 years, 8 to 10 years. But beyond that, to say we have really good data, I've not seen it.
Yeah.
There's another question on the chat. TAVI used to be reserved for high-risk patients. Now that it's changed and doing for low-risk patients as well, could treatment be a matter of patient selection?
So the question, I didn't understand very well the question. So patients at high risk or low risk regarding?
Right. So now that we're doing so low risk, intermediate risk, compared to years ago, like only a high risk patient, I guess the question is asking like anti-thrombotic therapy treatment. Would that be changed depending on the patient selection?
Yeah, probably. Obviously, as the surgical risk decreases, the risk of bleeding complications decreases also, because surgical risk is associated with some comorbidities that also increase the risk of bleedings. So, but these patients also have a lower risk of thrombotic events. So it could be that if we treat younger patients, it could be that the increase of bleeding complications and is not so obvious in comparison with high-risk patients. But the problem is that there is no signal in any of the events, myocardial infarction, stroke, etc., any subgroup of patients, etc., suggesting that increasing the number of drugs improves the prognosis. So I think the type of antithrombotic therapy is not going to be associated with surgical risk, I think.
And I have one more question. To detect the valve deterioration, I understand you do an echo. If there's increasing gradient, then you kind of start to suspect maybe there's a valve deterioration. Would the next step be going for MRI, or what's the next step after?
The problem of echo and valve thrombosis in echo is that the valve thrombosis, the presentation at echo is as an increased gradients. It is not infrequent that you don't see any thrombus, even in transesophageal echo. So usually it is a diagnosis if you have, for example, a mean gradient of 40 or 35 1 year after TAVI, it has to be a thrombus. So it makes no sense that it is another mechanism. Theoretically, a 4D CT scan, it could be more useful for detecting this problem. The question could be if we suspect that the patient has a valve thrombosis, if we have to anticoagulate the patient, even if we haven't proven the thrombus on the leaflet, or if we have to wait to the CT scan. I think that in most of the cases it is not needed to wait. But if we need a more accurate diagnosis, we should perform a TEE, although we have to know that the absence of thrombus that does not mean that the patient does not have a valve thrombosis, and a CT scan.
So, I'll share before we end, and maybe a little anecdote with the fellows. Maybe Raul, I've told you the story before. So Raul, you showed the paper from Circ Intervention 2015 that we published from Milano. But we actually, we were the first to describe valve thrombosis on TAVI valves. In like 2013, we published a case report in JACC. But it was interesting how we diagnosed it, right? Because I was in clinic and we saw this patient who about 4 months after his TAVI came back with a high gradient. And we did an echo and there was no thrombus. There's nothing on the echo. We just saw high gradient. So I had booked the patient for valve in valve in about 2 weeks from now. And then the same day I was talking about it, I was like, this is strange. 4 months after, 4 or 5 months after TAVI, I'm gonna have to do a valve in valve. And I remember that I spoke to Alec Vahanian because we were working together on a project. And Alec said, we used to see this in the old days with some of the old surgical valves. Why don't you try anticoagulation? Mm-hmm. And so we tried the anticoagulation, and then the valve got better. 2 weeks later, we saw another patient also with a gradient, but now a year out from his valve. And we tried it again, and it resolved, right? And that's where we sort of started diagnosing that valve thrombosis was actually, fairly common, more common than we knew. And it was just from a clinical observation from seeing patients in clinic. So I always like using the story for the fellows, saying, some of the best observations, some of the best clinical research we do comes just from making a clinical observation that you see in your daily practice, and trying to understand why it's happened.
Yeah. This is the good research, the research that comes from the questions you have about the patients.
Yeah, absolutely. And from that, then people started doing CAT scans and started finding subclinical leaflet thrombosis, but it all starts from just clinical observations. Raul, thank you so much. That was fantastic.
A great pleasure.
Thank you for joining us this morning. Have a great day back in Madrid, and stay safe, please.
See you soon. Bye.
Ciao. Ciao, ciao.